So I am giving part of this talk, and Dr. Melissa Baltuano, who is one of my colleagues, is going to be giving the second half, which is talking about a SUDEP project that we've been working on. So these are the disclosures. I do a number of the studies with some of the different vendors that you have seen out there. And our objectives on this talk is just to go over some basic definitions and facts of SUDEP as well as mortality and Dravet syndrome. Then we're going to go a little bit about what we know in terms of mechanisms for SUDEP in general and then SUDEP in Dravet syndrome particularly. We're going to look a little bit on what can be done in terms of trying to prevent SUDEP. And finally, again, we'll go on over a summary of the ongoing project that we are currently working on, where we're trying to identify some clinical markers of SUDEP in the Dravet syndrome population specifically. So SUDEP stands for sudden unexpected death in epilepsy, and that is a death that occurs abruptly without any warning or apparent medical cause in people with epilepsy. Now realize all of us have a risk of a sudden unexpected death, but in the population with epilepsy, that risk is 40 times as great. So it is the leading cause of death in patients and young adults and children with intractable epilepsy and accounts for about 40 to 50% of the mortality. SUDEP rates are often expressed in a number per 1,000 person years, meaning if in a year you had 1,000 patients with Dravet syndrome, how many would die of SUDEP? Or not just Dravet syndrome, but just with epilepsy. And the usual SUDEP rates are listed as somewhere around 1.5 to 5 per 1,000 person years. That risk does increase if you have intractable epilepsy, and that risk seems to be higher on the whole if you're an adult as opposed to a child. People whose epilepsy began in childhood years had an average age of SUDEP at 25 years, so as a young adult. But that's not the Dravet specific. We'll get to that in a moment. Now, looking at mortality in Dravet syndrome, Dr. Dravet, in her initial studies, had found a mortality rate of 15.9%, and that's usually what you will hear in a lot of the older literature. And actually, in a number of other surveys and studies, you see that there's a pretty big a range in the mortality in Dravet syndrome. That's from 3.7 to 17.5%. And again, how much of that is because of SUDEP also has a significant range. So different studies show the different numbers. And it can be anywhere from 15 to 61% due to SUDEP. And then the next most common reason for a death in Dravet syndrome is because of status epilepticus and the special kind of overall encephalopathy the kids may get when they have a very prolonged seizure. So see, these are some of the early studies that you see there listed, ranging from 2005 and 2010, and the different rates for mortality and the reason for the cause of death in terms of SUDEP or status epilepticus. Looking at a slightly newer study, this is, was done by Cooper and al. In 2016. You can see here on the graph that it lists the mortality rate of about 15.8 per 1,000 person years, or about 15% risk of death for patients with Dravet syndrome specifically across the age ranges of 2 to 20 years. The mean age was 7 years, and there was a Dravet-specific SUDEP rate here of the 9.3 per 1,000 years. And he was looking at 100 patients with Dravet syndrome, of which 87% had a sodium channel receptor mutation. So this is another study that was done by a Japanese group, European group. And what was very interesting here is they looked at mortality in Dravet syndrome, looking at 59 patients, although only 10 had genetic testing, with 7 having an SCN1A mutation. But they looked at the different causes of death per age. And the yellow bar here is SUDEP. So you can see that there is a little bit of an increase at the beginning and the first few years of life, then a dip and another increase in the teen years. And in this study, when they looked, though, there wasn't anything they can identify as a biomarker of this group of kids are at more of a risk of SUDEP than another group of kids. So one of the big questions then is overall, children with Dravet syndrome do have somewhat of a higher risk of SUDEP than other children with intractable epilepsy, and why might that be? And if we look at what we know are some higher SUDEP risk factors, they include epilepsy that is pharmacoresistant, meaning they continue to have seizures despite trying multiple medications. That there is an increased frequency or recent history of generalized tonic-clonic seizures. That there is a lack of treatment of anti-epileptic drugs or subtherapeutic level of those drugs. There is polypharmacy, meaning the kids or patients are on multiple medications, and that's really just an indicator that somebody has a very difficult to control epilepsy. There are frequent changes in anti-epileptic medications, the epilepsy is of a long duration, and the patients have intellectual disability. So if you look at that list of what makes SUDEP a higher risk factor, you can see how much of those risk factors apply to patients with Dravet syndrome. So it might be simply that they are at the higher risk category just because they have so many of the higher risk clinical symptoms. But there's also a question of if they could be at a higher risk for SUDEP because of something that has to do with the SCN1A gene variant specifically, and that question is still not known. So we're going to look a little bit about what causes SUDEP. Why is this happening? It's an extremely important question because if you know why something happens, you can try to identify how to prevent it from happening. And as I go through this, I'll tell you right now, we don't know why it happens. So I'm going to tell you some of the information that we have seen and go from there. Basically, when you pass away, your heart stops or your breathing stops. So those are the two big categories we're going to be looking at. But I did just want to mention this idea of cerebral shutdown because you will see it sometimes in some of the SUDEP literature. So looking at that first, this is really based on an EEG pattern, and that when patients have especially generalized tonic-clonic or sometimes focal seizures, on the EEG after all the chaos of the EEG and when the seizure's going on, when the seizure stops, there's a flattening of the EEG completely. And that's what people had then called, well, it's kind of a cerebral shutdown. It's not that your brain stops working. It's just that after all that energy it just put out in having a seizure, it just has slowed down. And on the EEG, it shows a pretty significant kind of flattening. That flattening, especially if it lasts over 50 seconds, is a biomarker of an increased risk of SUDEP. Over 50 seconds of that, your SUDEP risk goes up significantly. So that's one of the type of biomarkers when we go to the study that we're looking at later that Dr. Baltuano will be talking about. We're trying to find some other clinical biomarkers in patients with Dravet syndrome specifically that might help us identify who's at a higher risk factor. But it's during that time of after the seizure, when you have that slowing of all the brain waves, that's when a lot of your respiratory issue and cardiac issues do come about. And if we look first, sorry about that. Okay. So we're going to first look at cardiac dysfunction. And cardiac dysfunction has been identified as a potential mechanism of SUDEP. Again, if your heart stops, you will pass away. And different arrhythmias have been associated with seizures. That's why it was an easy thing to say, ooh, that might be the reason as to why this happens. You have a seizure, your heart starts not beating the way it should, you start not getting the blood to go where it needs to go, and then you start getting the mechanism of worsening heart function and hypoxia or breathing issues. They have seen in the first blue box here is a study that's done by Frank Halume in Seattle looking at mice models of SCN1A mice. So mice that have an SCN1A mutation, and he recorded some episodes of SUDEP. And he saw that in those mice that they did have a dysrhythmia, and then subsequently had the other respiratory issues, and then the mouse died. However, I will say that there was a recent study, which is the second colored box here, that comes from a multi-centered study in Europe, where they looked at a bunch of patients who have Dravet syndrome, and they had recordings of all of their heart rhythms that lasted for many, many days and months. And they were able to look at those heart rhythms around their normal activity and when they had their seizures. And they did not find that there were arrhythmias or a heart stopping at the time of the seizures. So it's definitely still an area that's really unclear. A couple talks down from me is going to be a specific heart talk in Dravet syndrome by Dr. Cantor. So he'll have much more information and details in that talk. So the next one for a proposed mechanism of SUDEP and Dravet syndrome is your respiratory dysfunction. And this is because seizures are also associated with respiratory difficulties, either hypoventilation, not breathing strong enough to fully get the oxygen in that you need for your body, or actually an apnea, or you stop breathing altogether. And seizures can commonly induce apnea and hypoventilation, or hypopnea. Now, it's interesting in that even if we say, yes, this is the reason why SUDEP happens, you still need to find out why exactly that happened if we're going to try to find out how to possibly have an intervention that will make SUDEP less likely. For example, some people have focused on serotonin as a possible reason as to why you have respiratory dysfunction as a cause of SUDEP, because we know that serotonin dysfunction in the brainstem can make you stop breathing. From that, people have looked at some mice models and have seen that giving some serotonin, such as with an SSRI or a selective serotonin reuptake inhibitor that increases serotonin in your brain, would help reduce the risk of SUDEP. It's also interesting that, as you guys are probably aware, fenfluramine, which is Fintepla, recently came out with an article that those kids who were in that study have shown to have a decreased mortality as compared to what is the natural history in Dravet syndrome. So again, just a thought that maybe if we can find out, if we can really dig deep and find out what is the cause of SUDEP, that is at the point where you might be able to make an intervention. And adenosine is another one that also has respiratory depressant in the brainstem. So there is a mouse model that was looked at in Iowa. George Richardson team and Dr. Kim is in Iowa, and they looked at a number of rodent models that have an SCN1A mutation. And what they found when they looked at their models with SUDEP is after spontaneously or heat-induced seizures, they had a central apnea that was then followed by the bradycardia. So again, suggesting for them, respiratory might be the primary issue. But at this point in time, I'll say again, we don't know which one is the primary root cause of SUDEP, and it might be different for different people or different groups of people. SUDEP and Dravet syndrome might be a bit different than SUDEP in adults who have temporal lobe epilepsy, which is another big group who have SUDEP. I will just mention, because I didn't have a slide on it, I realize, is that the gene regulation therapies that I think you guys have heard a bit about over the last day and a half, in the mouse models where they use those therapies, there was not only a marked decrease in seizures, there was also a marked decrease in SUDEP, which was huge. So what can be done to prevent SUDEP? At this point, very little, because we don't even know what causes it. But there are certainly some things that you can do in terms of when you looked at those risk factors that make SUDEP higher, you try to prevent those. So you try to have the best seizure control possible, working with your physician. Obviously, for kids who have an intractable epilepsy, you can't just keep piling on medicines until their seizures stop. You have to have that balance between seizure control and medication side effects to really maximize their developmental potential, maximize their quality of life. But you will work with your physician to try to get the seizures as well controlled as possible. You want to avoid seizure triggers as much as possible for your child because their quality of life is still important too. And certainly you can consider a seizure alert monitor. Now, the website I always recommend everybody go to for SUDEP information is the Danny Did Foundation. Do you guys all know about this website? A lot of heads shaking yes. This family actually lives in Illinois, so I know them quite well. It was a family, an uncle whose nephew had died of SUDEP, and after it happened, they realized they knew nothing about SUDEP. They didn't know that that was even a possibility. So they made it really their life to educate other families as well as physicians on SUDEP. Within this website, there is a device tab that I kind of outlined in red there that goes over all the different seizure monitoring devices, the MFIT monitor that goes under the mattress, the different watches, the SAMI movement monitor at night. So there's all sorts of different ways to try to detect if there's seizures at night. Because SUDEP can occur at any time, but the classic story of SUDEP is that a patient or a person goes to bed and they're found having passed away in the morning. They can occur from sleep, can occur from awake, can be witnessed, can be not witnessed. That's just one of the ways that you most hear how SUDEP occurs. So certainly being able to monitor at night for seizures may be helpful. But again, we wanted to look to see if there was anything, is there anything different about the patients who pass away from SUDEP? Is there seizure types or seizure lengths? Do they turn blue during their seizures? Or are they using a seizure monitor? Kind of anything that might be helpful in trying to just determine what patients in Dravet syndrome specifically might be at a higher risk for SUDEP. And now I'm going to pass over the microphone to Dr. Melissa Batuano, who is just finishing her epilepsy fellowship year with me at Lurie Children's and will be a practicing physician in a week in Oklahoma.
Good afternoon, everyone. It's truly an honor to be here at this conference and be able to share our work with colleagues, families, the DSF community, and everyone here today. So as Dr. Laux mentioned, I will be talking to you all about our ongoing research project titled Clinical Markers Associated to SUDEP in Dravet Syndrome. So the objectives of this study are to identify clinical markers that are associated with an increased risk of developing SUDEP in children with Dravet syndrome, and also to assess the actual risk of developing SUDEP with the clinical markers that we identify. So this is a retrospective study that gathers demographic and clinical information from parents, caregivers, or guardians of children with clinically or genetically diagnosed Dravet syndrome. We are using an anonymous online survey to collect data on children with Dravet syndrome as reported, of course, by parents or caregivers. We have two separate surveys available, one of them specifically for parents who have lost a child with Dravet syndrome. The survey link and QR code was distributed to potential participants via email through the Dravet Syndrome Foundation. And this is what they look like, and this is what the survey looks like when it's opened in a computer or a phone. So in order to start the survey, parents need to agree to participate by clicking an online verbal consent form that provides detailed information on the study. Overall, the survey takes about 20 to 30 minutes to complete, and participants are asked to share certain records or testing results, either by uploading them to our database directly or by sending them to our study email using a unique patient identifier that's created when the survey is started. Since our survey went live on March 25th of this year, we have received so far 113 survey responses, 104 patients who are living, and 9 patients who have passed away. After cleaning our data, mostly for incomplete responses, we currently have 68 patients in our control group and 7 patients in our case group. And with this cohort of 75 patients, we performed a preliminary analysis, a descriptive analysis, which is what I'll be showing you all today. So starting by the demographic characteristics of our cohort, we have a total of 75 patients, 54% of them female, ranging from 1.5 months to 33 years of age, with a mean age of 12.8 years. In terms of race and ethnicity, the majority of our samples self-identified as white and non-Hispanic, and 94% reported to have a confirmed SCN1A mutation. Regarding the characteristics of seizure onset, the mean age of the first seizure in our cohort was 5.5 months, with 56% of patients, as we can see on that first graph, reporting generalized convulsions to be the presenting seizure type, followed by hemiconvulsions in 37%. And in most cases, as we can see on the second chart, in about combined 70% of the patients, the first seizure lasted between 5 to 30 minutes or more, which means that these patients presented in status epilepticus. In about 75% of the patients, the first seizure was triggered by either illness, fever, vaccination within 3 days, or other factors reported by parents, for example, hot weather or hot baths. And in the rest, there was no identified triggering factor for this first seizure. Now, when we looked at epilepsy severity, we consider factors such as seizure frequency, seizure control, as well as if patients had a history of convulsive status epilepticus and the number of these episodes in their lifetimes. So the majority of patients in our cohort at the time of the survey were having about weekly seizures, which was reportedly by parents, an average to better than average from their baseline. Now, 75%, as we can see on the third graph, they had a history of convulsive status epilepticus occurring between 1 to 5 times in most patients, almost 40% of the patients in their lifetime. We are also interested at looking closely at breathing patterns during seizures, and we found that 63% of patients have cyanosis, which means blue discoloration, mostly perioral, so around the mouth. And the large majority of patients, so more than 70%, actually 77%, had abnormal breathing, and about 72% had abnormal, gasping during and after seizures. So we currently have a total of 7 cases that were reported of patients with Dravet syndrome who have passed away, which translates into a total mortality rate of 9.3%. The 2 main causes of death were probable SUDEP or status epilepticus, which represents a specific mortality rate of 4% for SUDEP and 5.3% for status epilepticus. Now, as you can see from this table, we are also looking, as I mentioned before, breathing patterns, sleep habits, use of devices, breathing patterns during seizures, cardiac issues, cardiac testing. And then other variables that we're looking at and we're including are parental SUDEP knowledge, CPR training, and then overall characteristics of epilepsy severity. So our goal, once we have more survey responses, will be to compare these variables between those patients who have passed away from SUDEP with our control group and see if we can identify any patterns, trends, or significant differences between these groups. So far, the characteristics of this specific group of patients are the following. So most patients are male, so 71% of them are male, white and non-Hispanic, which is also like the majority of our cohort, and all of them had confirmed SCN1A mutations. The ages at death of these patients range from 1 year and 10 months to 26 years, with a mean age at the time of death of 9.9 years. These children had a mean age of 5.6 months at seizure onset, with 71% of them presenting with convulsive or hemiconvulsive seizures, and 85% of them presented in status epilepticus. Over half of them had, as we can see there, about 57% had a known trigger at that presentation. So in terms of severity of their phenotype, all of the patients had convulsions around the time of death, and 71% had at least one lifetime episode of status epilepticus. And then over half reported cognition that was significantly below average. And they were, as a group, on an average of about 3 anti-seizure medications, and it is worth noting that even the younger patients were already drug-resistant, meaning they were on at least 2 anti-seizure medications. Now, on the right, we can see regarding respiratory and cardiac issues, 85.7% of the patients reported abnormal breathing and gasping after seizures, and none of them had cardiac issues, and when tested, all of them reported normal cardiac testing. Now, when we asked about parental and caregiver SUDEP knowledge, nearly all of the patients responded, or the parents responded that they knew about SUDEP. And a third of these patients reported finding out through patient support groups, while another 29% learned about it from their child neurologist. This finding highlights the importance of the work that is being done by the Dravet Syndrome Foundation and the collaboration that is still needed to spread parental awareness on this topic. So in summary, what I showed you all today are, keep in mind, preliminary descriptive findings. So we cannot draw conclusions yet. However, more research and participation is needed to identify characteristics that can help us identify those children with Dravet syndrome that have the highest risk of SUDEP, with the hope that we can find modifiable risk factors and try to prevent this outcome in these patients. So I invite everyone who is interested to participate in our study survey if you haven't done so already. You can do so by scanning the QR code that you see on the screen or typing the link in your computers or iPhones or phones. And there is also a postcard with details on this study and this information on your welcome packages. And so with that, I wanted to thank Dr. Laux for her mentorship on this project, the DSF for their support, and for having me here, and especially all of the families in the Dravet syndrome community who have participated and made this research possible. So thank you all for your attention today, and we can take questions now.
That was outstanding. Great job.
Thank you.
Very excited with your work, and I'm also very excited that there's going to be a doctor in Oklahoma that likes to do Dravet syndrome, so that's fantastic.
I was curious if I heard that there was a new genetic test available for SIDS, sudden infant death, and I wonder if that would also be helpful in SUDEP, and I just wanted to know your thoughts about that.
I don't know if it was a genetic test or just a blood test. I think it was a blood test for something. And to be honest, that just had come out. I had only read the headline. I hadn't read the article. I don't know if Scott or anybody else have seen that. But it's an excellent question, Janice. And once I look into it, I will let you know. I thought my scanning of it, the test wasn't commercially available yet, but I do need to look. We have no idea if SIDS and necessarily SUDEP have the same mechanism, but I think it would be very interesting just to see if that would be possible to even test for. Thank you.
I have another kind of SIDS-related question too. I was wondering, have you ever, with positioning SIDS, back to sleep and co-sleeping and those kinds of things, is any of that ever translating into SUDEP, like the position of the patient the person, or whether they were co-sleeping.
And certainly many of the SUDEP studies and our survey as well looks at how the child or young adult was found in, when they are found to have passed away. The problem, of course, is when you're older, you can certainly go down on your back, and if you're like me, you're not going to end up remaining there because people go all over the place. On one of the slides for mechanisms, I had on the respiratory one at the end, asphyxiation is also really thought to possibly have a prominent role in SUDEP and asphyxiation, meaning that your body does not get the oxygen in, and that's really going to the idea of, the child or person is found kind of face down, so they can't take that rescue breath after their seizure. So to answer your question is that, we usually would recommend following the advice of the American Academy of Pediatrics in terms of the SIDS advice for placing on the back. But it's after that, I think when the kids get older, it's impossible to necessarily stay like that. There are non-suffocating pillows. They're on the Danny Did website under that device section, and certainly asphyxiation, or the not being able to take a breath in because of an obstruction somehow, is a possible mechanism for SUDEP. You can just take mine.
I just want to know if you can go back to that slide where the parents filled in how they found their children, because obviously that's not something I think any of us feel comfortable asking on the Dravet group. And I just want to take a
And I can say that, it's right there. So we asked for circumstances of sleep or how patients were found, and it's very variable, so we haven't found any specific pattern. Of course, we have low numbers, but we haven't found a specific pattern for that particular question.
I had attended Day of Dravet several years ago down in Houston, and there was a physician that said that we're looking into correlation of specific mutations being more susceptible to SUDEP. Is there any research going on for that, or do we know?
Well, certainly in this study as well, all the mutations are being gathered. And I do know, and the other thing really to know, and we should have had this on a slide, is there is a SUDEP registry. And that is bringing out really important information. So a lot of the families I know of children who have died of SUDEP have gone on to that registry, and they are looking at the genetics just like we are here. So it's an interesting way of looking at SUDEP from two different points. They're looking at it from the SUDEP point as to, is there a difference for the patients with Dravet syndrome in all of their studies with SUDEP? And we're looking at it from the Dravet syndrome point of view of, is there something different for the kids who have passed away from SUDEP from those that don't? Both are looking at the actual genetic SCN1A tests.
Great. All right, we're going to take one more question.
I'm not sure how to ask this question, but on the last slide, I saw that it said some had autopsies. Is that something that would be recommended for more information to help discover a cause and treatment?
Mm-hmm. It's so difficult because if a child has just passed away, that's going to be probably the last thing on your mind. But certainly it would provide more information in terms of SUDEP. So there used to be a kind of an easy link, and I still have it at the office, on how a family could go about to get an autopsy after their child had passed away from SUDEP, and that information is used in that SUDEP registry, as well as separate studies like this that just look at the autopsy information. So yes, that would be helpful if that ever were unfortunately to occur.
Thank you both very, very much. presentation.